Unfortunately, I'm talking in Dr. Horwitz's behalf due to unfortunate settings, but at least I get to talk about a topic that's near and dear to me. Bear with me a little bit as I did get these slides yesterday. So the learning objectives for the talk are going to be, one, to review the risk grouping and who might be appropriate for prostate SBRT and hypofractionation, to review some of the background and rationale for why this might be a good thing to do for prostate cancer, quick look at some of the hypofractionation data, and then the details for how to actually deliver the treatments and accomplish that in a safe manner. So a little bit of background. Epidemiology is always important, and not to forget that prostate cancer is the #2 killer of men in the U.S., with a 1 in 6 lifetime risk of being diagnosed and a 1 in 36 risk of dying of prostate cancer. And there's the 2006 estimated rates, which haven't, in terms of the rankings, haven't changed significantly as long as I can remember. So when we're looking at prostate cancer, risk and risk stratification is always sort of critical, and there are multiple different risk algorithms to assign. When we're looking for who would be a candidate, I think we all would be the low risk group as defined by any of the models, or a subset of some of the intermediate risk group population would be candidates. My bias is less than 50% Gleason 7 and PSA less than 15, although there is variability in that group. Some would use Gleason 3+4 versus 4+3 for that. Hypofractionation for prostate cancer, the question of why should we be doing this? There's some really obvious reasons why we'd like to do this. One, convenience. Patients don't want to come for 8 or 9 weeks of treatment. Allows for increased utilization of limited resources. It's certainly less expensive than more protracted courses of therapy, and there may be some biological rationale for why there might be therapeutic advantages, both in control and decreased toxicity. So the logic between conventional fractionated radiation versus radiosurgery, look with standard radiation, we're treating a larger volume for coverage of subclinical disease. And with SBRT, we're using as small a margin as possible. And with the conventional radiation, we're really limiting our deliverable dose due to normal tissue toxicity. Whereas with SBRT, it's more of a volumetric issue of how much we can treat. So I think the point he's trying to drive home here is that we're using fractionation to allow for normal tissue sparing in the conventional setting. With SBRT, the focus is really on volume avoidance. So it's a little bit different way in which we're trying to minimize the risk to our normal structures. So for prostate, especially for low and low intermediate risk prostate cancer, most of these is going to be in the gland. It's mostly going to be gland organ confined disease, which would be very amenable to an SBR type approach. And it's also a site where we have multiple trials which have shown benefits to dose escalation in terms of at least biochemical control. Survival endpoints we can debate separately. But hence, the hypofractionation approach is sort of uniquely suited from just a target perspective in this clinical situation. When you start factoring in some of the biology and utilizing alpha-beta ratio for it, the alpha-beta ratio is a nice measure for tissue sensitivity to dose fractionation and can be estimated from clinical data. So to refresh, if two different estimates, and I think most people are going to be familiar with the hypothesis that prostate has a low alpha-beta ratio. I'll review that in a second. But the impact on actually cell survival based upon dose fractionation is pretty dramatic and becomes more dependent on fraction size as we get into the lower alpha-beta ratios, as shown on the left cell survivor curves, as compared to what we normally think of for tumors with the alpha-beta ratio of 10. And for a low alpha-beta ratio here, looking at the direct impact in effectiveness as the number of fractions decrease. So the x-axis here, the number of fractions are actually decreasing left to right, and fraction size increasing left to right. And you're seeing a equivalent dose splitting between the normal tissues and the tumor. So what's being highlighted is that if you really do have a low alpha-beta ratio, you may be selectively improving your therapeutic gain, your therapeutic ratio, by going to a hypofractionated approach And this gain may increase as you further decrease the number of fractions and further increase your dose delivered per fraction. There have been multiple studies that have looked at different doses and fractionations for prostate cancer, and when pulled together in a meta-analysis, the hypothesis from the combined data really was an alpha beta about 1.4, but with a wide range. However, all of these are generally we would consider lower than our normal alpha beta ratio for normal tissues. So although not 1.4 per se, all the data was pretty consistent that the alpha beta ratio should be low. There are a number of hypofractionated approaches, and your assumption for alpha beta ratio can have dramatic differences in the actual calculated bioeffective dose you're delivering to the tumor, as is highlighted here by a bunch of the studies looking at sort of more of the extreme hypofractionation doses, 6 to 9 or 10 gray, and the biodelivered dose. And you're seeing a dramatic step up in the equivalent BED for the same actually physically delivered dose based upon what you assume the alpha beta ratio is. And that makes, you have to be somewhat careful when you start doing this, in that the assumptions you make may have very different effects depending on what you assume. So the implications of some of these observations is that the prostate cancer may be more sensitive to the size of the fraction than what we think of usually for normal tissues, and as was shown on the one curve, would predict for a therapeutic advantage to hypofractionation. Sort of provides a very nice biological rationale for applying stereotactic techniques and extreme hypofractionation to prostate cancer, and given the burden that this disease has on society, would play a critical role in maybe decreasing the cost of treating this disease, and also the patient convenience and increasing access to care. So this is a review of a number of the different moderately, I'll call them hyperfractionated studies that have been performed. And really you can split some of them into two groups, a group of studies which looked at can we improve outcome by effectively increasing dose utilizing hypofractionation, theorizing that the lower alpha beta ratios would result in the higher bioeffective doses shown on the prior slide, and they didn't. So the studies that hypothesized that we should do better by hypofractionation didn't really bear that out. The Fox-Chase study did show an increase in GU side effects, but I think it's important to note that it was really driven by patients who had a high IPSS score or high urinary symptom index prior to treatment, and wasn't really shown in the lower IPSS score patients. There's a second group, some of which are ongoing, looking at, from a different approach, can we get non-inferiority and decrease toxicity? So trying to pick a bioidentical dose utilizing the delivered radiation and thereby improving therapeutic ratio by using the hypofractionation to drive down toxicity profiles. One of these studies is the CHIP study, which is looking at 3 gray doses per fraction compared to a standard dose of 74, and it's 2 different dose schemes in the comparison. Basically, it's 1 additional fraction of 3 gray to account for isodose differences or bioeffective dose differences between an assumed alpha beta ratio of 2.5 or 1.5. And assuming that you have a normal tissue alpha beta ratio of 3, which you might argue might not be great for bladder or rectum, in theory this would show a therapeutic gain. This is the groups that they included, and I think it is important to note that all patients in this study did receive hormonal therapy, and the interactions of hormonal therapy with dose escalation or hyperfractionation, I think, are not well defined and probably warrant additional study. So a little bit of a confusing or busy tables, but basically this is your toxicity profiles based upon grade 2, 3, and 4, and incidence over time. And basically the punchline is that there really wasn't a difference between the toxicity profiles. This is the patient characterization and risk group for this study. And this is the time to biochemical failure and prostate recurrence. Note that this is 90%, not 95% confidence intervals. So in the non-inferiority design, there was they were able to conclude that the 60 gray and 20 fraction arm, remember this is a non-inferiority trial, was non-inferior to the standard fractionation, although the same conclusion could not be made for the lower dose 1 fraction short arm. And both had very low side effect profiles, as was in terms of grade 3 or grade 4. And I mean, their hypothesis was that it certainly can be delivered, the 60 gray and 20 fractions at 3 gray. The RTOG randomized study, again in lower risk cohort, looked at 2 different fractionations, 73.8 versus 70 and 28 fractions. In this study, again, no hormonal therapy, so there are differences in how hormonal therapy has been utilized in these trials. There was no difference in the disease-free survival interval. There was no difference in the biochemical recurrence. However, here it was again thought to be isoaffective with decreased toxicity. There was no difference in the acute GI and GU side effects. However, similar to the Fox-Chase study, there was an increase in the late GI-GU toxicity between the 2 arms. So the conclusion was that it seemed reasonable. There was a slight risk of increased grade 2 toxicity for the hypofractionated patients. So the really is, where do we go? What can we do this? How can we apply the SPRT techniques? What dose and fractionation should we use? What type of frequency? And there's some data here also to guide us. This is some of the early studies that really pioneered the use of the stereotactic techniques and published their data, all of which showed, at least with early follow-up, very high rates of local control with low toxicity profiles. There is one phase 2 randomized trial looking at 2 different hypofractionated approaches. And this one is a little bit unique in its design, but it was one of the standard stereotactic approaches versus a 12-fraction hypofractionated, more moderately hypofractionated course. And this was looking actually at changes in patient-reported outcomes, so EPIC quality of life measures, and evaluating differences between reported EPIC scores, and looking for a difference there in terms of a way to validate the hypofractionation benefit. These are the secondary endpoints of the trial. These are the patient characteristics. And in terms of differences, there really wasn't a whole lot of toxicity observed. Either in the acute grade 3 or grade 4, rates are both very low between the 2 groups. I'll skip that. So the conclusions from the phase 2 trial was that both of these regimens seem to be very well tolerated with very low rates of patient-reported outcomes and toxicity, and suggested that there needs to be a comparison of a hypofractionated radiation to a standard fractionated course in a randomized way. So how do we deliver stereotactic prostate radiation? As with any of these, we have to worry about the normal structures and try to do everything we can to protect them. So what are the structures we're really worried about? Bladder, rectum, femoral heads, seminal vesicles, penile bulb, and skin. We generally consider all of these as solid organs. The bladder is contoured in its entire volume. The rectum is contoured from the bottom of the ischial tuberosities up to the anterior flexion of the rectum to the sigmoid or the rectosigmoid flexure. The intraprostatic urethra, I don't personally use a Foley. I use MRI for my to identify the intraprostatic urethra, but it's which is relatively easy to do. The seminal vesicles are contoured from the cranial aspect to the prostate superiorly as one structure, and everything outside of the target volumes is considered normal tissue as unspecified normal tissue. The GTV would be defined by the physician as all known disease. For the purposes of prostate SBRT, they're defining it as the prostate only. And as the CT is the planning study, the CT serves as the definitive volume, with MRI, which I use a lot of, is a guide. The CTV is defined as the GTV in their situations. Then for the PTV, a tight margin is placed of 3 millimeters. They have clips, and if they're using that, he's willing to accept a tighter margin of 2 millimeters with the adaptation of the intrafraction tracking that affords. At least 7 non-opposed beams is what they're using. I have a propensity to using ARCs, and axial or non-axial beam arrangements are certainly appropriate to accomplish the necessary protection of the normal structures on your DVH. If you like to have a dose, the PTV dose of 1.2 in terms of SPRT planning ratio, the volumes, you want to be aware of your hotspots and less than 15% of volume outside of the PTV receiving the prescription dose, and minimize. They're like to shape the hotspots into the peripheral zone. I take a slightly different approach. If I can see areas of suspicion on an MRI, I'll actually give those areas a dose of up to 40 gray over the same course, or shift the hotspots into the areas of gross disease as visual as MRI when possible. And sort of standard dose constraints in terms of hotspot avoidance, as I'm now over my allotted time. Dose constraints as used at Fox Chaser is listed here. He's pre-medicating with the alpha blockers prior to treatment. I think the prep for simulation is of critical importance, certainly simulating everybody with a full bladder. We definitely also do a prep with milk and magnesium enema prior to simulation. They're repeating the bowel prep on the days of treatment. I have not, although we utilize our cone beam CT to confirm bladder and rectal filling, and if inappropriate or not suitable for treatment, we'll have the patient get off and evacuate or drink depending upon the need. And I limit my patients to IPSS scores less than 12 based upon Fox-Chase studies, so I haven't been pre-medicating, although if I can get them to an IPSS less than 12 on an alpha blocker, they remain eligible. And this is the current study, I think that's open at Fox-Chase, analyzing this. So summary points, hyperfractionation offers potential advantages over standard fractionation. The available clinical evidence is consistent with the low alpha beta for prostate cancer. Didn't really go over that. And moderate fractionation appears safe with longer follow-up from the studies. More extreme, I think, is also up and coming and quite reasonable. And that's it. Thank you.